we have Dr. Samin Sharma, who is going to talk on management strategies in the year 2016.
Okay, he has to find the slides now, right? So next 10 minutes, I'll just discuss latest in our management strategy of acute coronary syndrome, unstable angina and non-STEMI, because I won't keep it for the STEMI. Clearly, a lot of growth has taken place, which has led to decrease in mortality of the cardiovascular disease process, and particularly the STEMI PCI. And I think the management of the acute coronary syndrome non-STEMI PCI with the invasive strategy has established its role in the treatment, also leading to some of the decrease in mortality of these cases. Have been repeatedly shown, but key is the difference of whether you have stable plaque or you have STEMI or non-STEMI. It depends on the degree of thrombus, how much is the arterial blockage, and basically non-STEMI is the partial occlusion, and of course the extremes are asymptomatic and death. We all know that your positive troponin is non-STEMI. If not, positive troponin is unstable angina, which is differentiate us from the STEMI patient, which is ST segment elevation. What has happened? We actually don't know the clear-cut data in India, but definitely we know outside. The STEMI numbers are going down and unstable angina, non-STEMI numbers are going up. And this actually makes almost 50% of the cases which present now in the hospital for management of acute coronary syndrome. Now, one thing which I want to highlight, one of the very early study that shows that once you have a STEMI, which is on the left side, that ST segment elevation had a higher mortality in the short term, which is 30 days. But let's see what happens on the right side. Once you get the non-STEMI, which is your ST segment depression, you start crossing over the mortality of the ST elevation region. We know exactly to treat ST segment elevation. But what we don't know, how to treat, how to triage these patients with a non-STEMI, and they're a very heterogeneous group of patients. And key is that whatever we see, the patients develop this acute syndrome, it's just at the tip of the iceberg. Because unless you take care of the factor, and that is part of this convention, is risk factor modification and identification. Unless you take care of the basic subclinical risk factor, patient will keep coming back with acute coronary syndrome, and that is what our goal should be, to prevent what is subclinical so clinical does not occur. And this is how it looks on the angiogram. It's not totally occluded. You can see a dynamic angiogram, even at the small clot at that ruptured plaque in that LAD, and the thrombus actually is going downstream with the injection. And not every non-STEMI is similar. There are various scoring systems which have been developed. Most commonly used is the TIMI risk score when patient present with unstable angina and non-STEMI, taking care of the 7 factors of the age, more than 65, 3 risk factor, significant coronary lesion, ST segment deviation, severe angina within 24 hours, or use of aspirin or cardiac markers. And then they put the patient in the low risk, if 2, intermediate 3 to 4, and 5, 6 or 7 in the high risk group. And of course the troponin is the most important of them because any release of troponin has a gradation in terms of follow-up mortality and so. There is another risk score which is commonly used called Grace risk score, which takes into all these in account the age, patient's Philip class, systolic blood pressures, and come up with the number that a score of more than 140 is the high risk from the Grace score, which is used in many studies and so. There is one also Pursuit, but usually we TIM and Grace, both are available actually on the risk score app, and you can classify patients when they present. Why it is important? Because subsequent management of these patients is dependent on what risk category the patient is. Because any patient who comes in with acute coronary syndrome, we start multiple therapies of aspirin, ADP receptor antagonist, heparin, unfractionated low molecular or pentasaccharide, or fondaparinux, or some cases the direct thrombin inhibitor with a bivalirudin, some cases 2B3A inhibitor. But then we decide who should go for revascularization. Clearly, thrombolysis is not indicated in patients with a non-STEMI. Yes, about 2/3 of patients undergo cardiac cath and subsequent intervention. 10% goes for bypass surgery, and about 1/4 of patients are managed medically. More importantly, even if whatever you have done, whether medical therapy or invasive strategy, acute and long-term medical therapy is important, as I emphasized, to prevent the recurrence of this event. So over the years, we actually have evaluated should the patient be only on medical therapy or the invasive therapy, and this basically has given the answer by numerous trials. 11 trials of 11,000 plus cases, only one trial which was negative was the Vanquish. There were 3 neutral trials, ICTUS, MATE and TIMI 3B. What is positive is the ISAR-COOL, RITA, VINO, TRUX, TACTIS 18, FRISK 80 and latest FRISK 2 and after 80. All those trials showed favor of invasive strategy. What does that mean? That by using the routine invasive strategy compared to wait and watch policy, you have a invasive strategy causes lower death and myocardial infarction, lower angina, lower rehospitalization, and of course that if even at a long-term follow-up, you start beyond the in hospital of 4 weeks, the 6 weeks, you go to a 2-year follow-up, again, message lower mortality of the invasive strategy with a lower myocardial infarction and unstable angina. We have few studies now, 5 years. Actually, recently they presented 10 years of the FRISK, ICTUS and RITA, all again emphasizing or underscoring the importance that routine invasive strategy is better than the selective invasive. What does selective invasive means? That patients who just become very unstable after the medical therapy. But key is the routine means that patients comes in and you made the diagnosis of acute coronary syndrome and they go for cardiac catheterization and so. And this is of course the real benefit is in patients who are high risk and of course lower in the low risk. What about more than 80 years of age? There is a specific trial of 440 patients in the 80 years of old. Again, we always say in the old patient we should wait. Not true. Clearly the primary endpoint of 41 versus the conservative 31 and of course death, myocardial infarction, and you can see the conservative strategy is giving rise to the event rate was clearly lower in the invasive strategy compared to the conservative strategy. The key is that even in older patient, it makes a point that this patient should go to the cath lab sooner and rather than wait and watch. So to whom patients should go to the cath lab once they present, these are the common, which we know, recurrent angina, besides having the TIMI risk score, which are the component, and most important is the patient with a positive troponin marker. And anytime you have LV dysfunction, dynamic EKG changes should go for cath, and others could be conservative, but with the low risk, and patient sometimes may even not have cardiac problem. We know many of these acute coronary syndrome may be dyspepsia, but those cases will not have EKG changes, will not have troponin positive. Then question comes, you decided to take them to the cath lab, you do it within 24 hours or should you wait for 2 to 3 days? There are 2 trials actually done to answer that question. 24 hour, which is the Timex, again showed that in high risk patient, taking them to within 24 hour was much better, 14% event rate versus 21.6 if you delayed more than 24 hours. So all went for the cath lab, but early was better. So clearly that is, you don't have to wait when you decide invasive strategy that I'm going to do in 2-3 days. No, do it within 24 hours. Then second, this basically more so for the high risk as shown there. Question was, what if you want to take them to, just like a STEMI patient, take them to the cath lab within 2 to 3 hours. And this is by the ABORT trial and basically showed that yes, taking them too early is not beneficial because many times you need medicines to work and you have a little higher myocardial infarction. So it's completely okay. The patients with the non-STEMI acute coronary syndrome, you take them to the cath lab within 24 hours and so. So basically to conclude that non-ST segment elevation comprise about 75% of our all ACS admissions. Early risk stratification should be performed using symptoms, risk factors, EKG and biomarkers. Commonly used risk score TIMI, very simple to use. A routine early invasive strategy results in reduced early and late death, MI, rehospitalization, and especially in acute, in high-risk patients, and nothing is gained by waiting. Catheterization and revascularization should be performed within 24 hours, not that very early, but 24 hours, especially in unstable and high-risk patients. So clear message by numerous trials in this field. So basically, how do we take, just with my last slide, to put everything together, we do when patient present for the acute coronary syndrome, with plaque stabilization to prevent in-hospital event and prevent the intermediate and long-term event. How do you take care of the in-hospital? Clearly, PCI with stenting, high-risk patient, aggressive antiplatelet, antithrombotic therapy, get your good part of your intervention, minimum complication, and then of course, subsequently, systemic treatment to stabilize this vulnerable plaque and stabilize patient's risk factor by reducing thrombogenicity, by antiplatelet therapy, reducing plaque lipid content, which has been spoken quite well by multiple speakers here, and of course, very elegantly by Dr. Jagat Narula, that statins, PCSK9 inhibitors now, decrease inflammation, improve endothelial function, increase plaque collagen contents. There are many other work being done in this field with the purpose that by really managing these patients, decreasing their systemic vulnerability, risk factor modification, that acute coronary syndrome plaque will not rupture. Thank you very much.
Dear friends, I think this was a very important session of American College of Cardiology, and all the four speakers, Jagat Narula, H.K. Reddy, Pawan Sharma, and Samin Sharma, have done a wonderful job. And the Samin's comment were very right, because we preponed this lecture, and this was at lunchtime. So it was looking the audience less, but I knew in my heart it is being listened by everybody, even in the cafeteria, wherever people are eating. And the information which is given by Samin is really enormous. I think the way he's shown the statistical data, how we have to evaluate our patients, everything was of a great application. I really wanted more interaction could have taken place. That's what I also felt. But I'm sure other speakers also, like H.K. Reddy and Jagat Narula, have spoken a lot on this subject. If there are any comments from anywhere, maybe one or two comments we can take among us, the panelists sitting here, or anybody. Poonam, you want to say something on acute coronary syndrome and the role of ECMO technology?
I don't want to say anything after a stalwart like Dr. Samin Sharma has spoken, but yes, I would say something. The role of cardiac biomarkers is emerging in a very good way for immediate risk stratification, especially in the emergency department. So the delay that was once seen, I'm talking of the Indian scenario, what we see in our emergency department at AIIMS, the delay that one used to see is no longer there. Immediately the cardiac biomarkers are done depending on their rating, the streptokinase, urokinase, the therapies are given, patients are shifted, there's no delay in doing a CT angio. And I think that entire thing is giving rise to the birth of the next level of prevention, that is the use of mechanical circulatory support wherever one is needed. So things have gone very fast, and I think the students have to read lots more. There's so many papers, but learned a lot from what you are doing in your institution, and I'm sure there'll be many takers here, even though less were listening. Thank you.
Great, good to know all.
Ravi Kasliwal, you want to say anything? I think it's very important. We'll conclude this session here. Yeah. And let's give a big hand to Dr. Jagat Narula, Pawan Sharma, Samin Sharma, and H.K. Reddy.
Ladies and gentlemen, the honoring of the international faculty members is in progress, being done by the Secretary General, Dr. Satish Gupta. We have a shawl, a gift, and some in-house preparations.
Dr. Ravi Kasliwal, may I request you to come on the dais, please? Take Ravi ko de dena shawl. Ravi.
Ladies and gentlemen, Dr. Ravi Kasliwal would be conferred with the award for
I
outstanding
request all of
contribution
you
in
to please
cardiology.
put on a shawl. We are going to have a good photograph.
We have the award for the outstanding contribution
Ravi,
in cardiology in the
give to
world
Ravi Kasliwal.
for Dr. Ravi Kasliwal.
Don't disappear. I request Dr. Naveen Sinanda, Dr. Pawan Sharma there. Pawan Sharma. Stay here. Stay here. Stay here. Jagat. May I request you and Samin to put on a medallion to my very fast friend Ravi Kasliwal. He has come all the way in a crisis. I know what he was facing in Medanta MedCity, huge rush, but he has just come and he told me, for your support, HK, I'm here. This is a token of appreciation. On behalf, I'll request both of you to please join. And now I request Naveen and Satish to put on a medallion. He was missed yesterday in the inauguration program. Pawan.